Finals SAQ6 Traumatic Brain Injury. The case: a 54-year-old patient is admitted to the emergency department following a traumatic brain injury. A CT scan reveals only cerebral edema. A. What is secondary brain injury and when is it likely to occur? 2 marks. Secondary brain injury is deleterious changes that happens over hours to days in the brain as a consequence of the initial injury mediated by inflammatory, neurogenic and vasogenic processes, compared to primary brain injury, which occurs due to the initial insult depending on the nature, intensity, and duration of impact. Brain injury features. Macroscopic features include fracture, contusion, hematoma, cerebral edema and diffuse brain injury, and microscopic features include cell wall disruption, increased membrane permeability disrupting ionic hemostasis. B. Outline the main physiological and cellular changes associated with secondary brain injury, 7 marks. Primary injury, for example due to intracerebral bleeding, may exhaust the compensatory capacity of the brain, increasing ICP. Initially, as one component in the closed compartment of the cranium increases in size, it is compensated for by a decrease in size of another component, such as intravascular blood or CSF. Ultimately, this compensation will reach its limit and ICP will start to rise. This results in cerebral ischemia and hypoxia. Excitotoxicity. Inflammation and local tissue damage causes excessive release of excitatory neurotransmitters such as glutamate. This results in calcium influx to cells, cell edema, and death. Vasogenic fluid accumulation. Dying cells release mediators such as platelet activating factor, leukotrienes, and oxygen-free radicals. These increase blood vessel permeability, causing vasogenic fluid accumulation, increased ICP, hypoperfusion, cerebral ischemia, and neurodegeneration. Loss of cerebral autoregulation exacerbates cerebral edema and increases ICP. Seizures will cause increased ICP, exacerbates poor cerebral perfusion if untreated, and leads to increased PaCO2 and reduced PaO2, and this leads to reduced brain autoregulation and increases metabolic demand. Other factors increasing secondary brain injury includes hypoxia, hypotension, hyper or hypocapnia, and hyper or hypoglycemia. These worsen the ability for the brain to autoregulate, leading to direct changes to brain tissue size, increased ICP, reduced oxygenation, and perpetuating a downward vicious cycle. C. How can secondary brain injury be minimized in this patient? 11 marks. Assess and manage this patient simultaneously, adopting an ABCDE approach. Airway. Intubate and control ventilation if the patient is unable to protect their own airway. There is loss of laryngeal reflexes. GCS of patient less than 8. Patient hypoxic, hypercarbic, or having seizures. Cervical spine control. Immobilize if there is possibility of injury. Ensure that cervical collar does not obstruct venous return. Respiratory. Target PaO2 of about 100 mmHg and PaCO2 of 35 mmHg. Keep PEEP less than 15 cmH2O to maintain oxygenation and allow unobstructed venous return. Monitor oxygen saturation and end-tidal CO2. Cardiovascular. Ensure IV cannulation is achieved. Maintain MAP of more than 80 mmHg using isotonic fluids and vasopressors as necessary. Avoid hypotonic fluids. Target higher MAP if ICP is raised. MAP measurement by intra-arterial blood pressure. Optimize venous return with head neutral, tube ties not being too tight, and 15 to 30 degrees head-up tube. Paralyze the patient if coughing or straining on the tube. Urinary catheterization to guide fluid balance. Neurological. Target cerebral perfusion pressure of more than 60 mm mercury, intracranial pressure of less than 20 mmHg, blood sugar of 6 to 10 millimoles per liter, adequate sedation to reduce CMRO2, treat seizures to reduce CMRO2, and treat fever to avoid increased CMRO2. Manipulation of ICP spikes. Temporizing measures includes hyperventilation to bring down PaCO2, mannitol 0.25 to 1 grams per kg, or 5% hypertonic saline at 2 ml per kg. Keep sodium less than 155 millimoles per liter and plasma osmolality less than 320 milliosmol per liter. Discuss with neurosurgical unit if ongoing coma, ongoing confusion, seizures without recovery, and progressive neurological abnormalities. Consider transfer for decompressive craniectomy or other neurosurgical interventions. Seek other injuries causing blood loss, which may prevent maintaining MAP or hemoglobin at adequate levels for brain perfusion.